Hello, my name is Anne-Marie Brown, and I am the current Vice President for Nursing for WIFPICS, the World Federation of Pediatric Intensive and Critical Care Societies. It has also been my honor to be one of the co-chairs of this first annual World PICU Awareness Week. Luca Tortorolo, who is my co-chair, will also wrap up our introductions this morning. We hope that you have enjoyed this opportunity to begin to learn a little bit about the nature of pediatric critical care from different regions of the world and from different disciplines that participate in the care of infants and children. You will also hear a welcome and response from our current PICU leaders, Dr. Satoshi Nakagawa, our president, and Dr. Brenda Morrow, our president-elect. And with that, I hand you over to Dr. Nakagawa.
Emily, thank you for your kind introduction. I'm Satoshi Nakagawa. I'm currently the president of the World Federation of Pediatric Intensive and Critical Care Societies. Welcome to the World PICU Day, the last day of the PICU Awareness Week. We are very happy to have you to join this session. This is the true multidisciplinary PICU team celebration. We have physicians, nurses, and the physiotherapists, as well as the pharmacists and other healthcare workers to join to communicate each other and strengthen the ties among us. And this is a very good opportunity to show our activity to the other field of the people. And I would like to congratulate everyone to join in this very special session. Thank you. I'd like to introduce Brenda Morrow. She's the president-elect of our federation. Brenda.
Thanks, Satoshi, Anne-Marie, and Luca. Yes, so I'm Brenda Morrow, and I am the president-elect of WIFPICS, as Satoshi mentioned. I'm also a professor in the Department of Pediatrics based in Cape Town in South Africa. And maybe most importantly, I'm a physiotherapist by training with many years of passionate experience clinically and in research in the PICU. And with that, I'm so excited to have been part of this wonderful World PICU Awareness Week in 2021. It's really been a fantastic week, I think, of global and regional interdisciplinary activity, focusing on raising awareness of topical issues and advocating for improved critical care services across the world. And as a physiotherapist, I'm especially excited to see all the interdisciplinary input from nurses, doctors, allied health professionals from around the world, because we know that it's only through a dedicated team that we can really give the best possible care to our critically ill and injured children. So thank you for being part of this, and I look forward to what the rest of the day has to offer. Thanks, Anne-Marie.
Hi, this is Luca from the space station, where Anne-Marie sent me to check and coordinate with her all the PICU week we had. And I think I will remain until the next year in May, when we'll start the new PICU week. In the normal day, I am a pediatric intensivist working at the ICU of University Hospital Gemelli in Rome, Italy. And I'm also a professor of pediatrics. I want to tell you that it's almost 30 years I was in a PICU. Since when I entered for the first time, it opened my mind, because it's really a world of things, a world of person, a world of resource, a world of things of doing. So different professional, different persons, different problems. But then it's only 2 years I am in the World Federation, 3 years I'm in the World Federation, and it opened again my mind, because I will face PICU from different parts of the world. So it's a word in the world. And that's rule that Anne-Marie gave me to send me on the space station up here, give me more an idea that the world is very different, but the difference is the power of PICU, is the power of World Federation, and we hope that the PICU week is going to be something that they make difference and make difference a resource for everyone. And the key word is going to be listening the others. So we are not so allowed to listen. And in this week, we listen different part of the world, different PICU, different problems, different professionals. So difference is our word. Thanks.
To acknowledge our tangata whenua, I'd like to open with a karakia. Whakataka te hau ki te uru, whakataka te hau ki te tonga, kia mā kina kina ke uta, kia mā taratara ki tai, e hi ake ane te arakura, he tio, he huka, he hauhau, tihei, Māori ora. There are a number of changes that will have a lasting impact on multidisciplinary PICU care. As mortality decreases, the focus has changed from optimising life for PICU survivors and looking at more holistic long-term outcomes from ICU care. We have a greater number of complex patients requiring long-term technical support, which requires a very high level of multidisciplinary support. Our PICU patients are growing up, and we'll need to work out how to effectively transition them. Our communities have greater expectations of PICU care. This is combined with higher acuity and patient numbers. These changes require a cohesive, multidisciplinary team approach where we all work to our strengths as equal partners to provide the best care.
COVID has certainly changed the landscape of hospitals and parental presence and visitors. But what hasn't changed, and hopefully will never change, is the need for compassionate and caring caregivers and team members. During, I would say, the most scariest admission we've ever had to a critical care was at a time when she was suffering ARDS. And they were pulling out all the stops, all the last resorts. And I remember specifically it was Mother's Day, and the prognosis looked very grim. And it was very scary to be there and be surrounded by machinery and by equipment that was all doing the job of saving her life, but also seeing all the other families struggle and children struggle and codes being called. It was a lot to take in. And on that day in particular, I was quite emotional, as you can imagine. And the doctor popped his head in and he asked if there was anything he could do. And through tears, I just told him I needed him to save Mickey's life. And I knew that they were already doing everything that they could, as were the machines attached to her. And so he pulled up a chair and sat beside me at her bedside. And we sat there in silence for about 20 minutes. He didn't rush off. He was just present. He wasn't doing, he was just being. And he was present with me. And I felt great support in that.
The fact that we are currently in the process of switching to a paperless system will most definitely have a lasting impact on our multidisciplinary PICU care. This is especially beneficial to our younger generation of nurses who are technological orientated and who are our future nurse leaders within our critical care setting. As we all know, that the pediatric intensive care environment can be very daunting and it comes with its own stresses. Technology are taking over the world and healthcare systems are not excluded.
A crisis like the one we are facing with COVID pandemic requires quick thinking to face the uncertainty. Therefore, we need to have a multidisciplinary approach to ensure we are able to forecast and prepare for the futures. ensure the authority met the expectation with patients' care. One of the main challenges at the unit, how to enhance the environment to maintain staff resiliency and reduce work stress-related issues. We're working as a multidisciplinary approach to have a better well-being for the staff and for the environment, which has helped us as one team to overcome new challenges during the pandemic crisis.
The developing countries are witnessing a rapid growth of subspecialty programs in pediatrics. We are empowering our nurses to get involved in patient care, decision making, and nurse education. So the two things which will have a long-lasting impact in PICU care are the involvement and training of nurses and also the development of PICUs in smaller or tier 2 cities.
Right now, we're focusing on staff well-being and mental health support with the employment of a clinical psychologist on our unit. We're also improving staff recognition with the use of Kudo certificates, which act as a positive feedback initiative.
Creo que uno de los desafíos más grandes y cambios más importantes que se ha evidenciado en general en las áreas críticas pediátricas en los últimos años es integrar en el equipo de trabajo una mayor cantidad de profesionales especialistas en áreas críticas pediátricas. Y es justamente ese cambio uno de los más fuertes, uno de los puntos más fuertes que hemos experimentado en nuestra unidad. La inclusión de equipos fuertes de trabajo multidisciplinarios, médicos especialistas, enfermeras en áreas críticas pediátricas, kinesiólogos terapistas respiratorios en áreas críticas pediátricas, nutricionistas especialistas en el área y técnicos paramédicos que forman parte del equipo de atención continua durante 24 horas para nuestros pacientes. Han permitido optimizar de manera directa las metas institucionales con beneficios que son directos para cada uno de ellos.
At the Children's Intensive Care Unit in KK Women's and Children's Hospital Singapore, we look forward to a new exciting journey towards early mobilization in pediatric patients requiring intensive care. We're just starting out and have developed guidelines to help the team in assessing, executing, and evaluating the outcomes of our effort in early mobilization. Studies have shown the debilitating effects of a PICU admission and the potential for positive outcome of early mobilization. This initiative can only be achieved with excellent collaboration amongst the multidisciplinary PICU team members, and we look forward to walking our very first ECMO patient.
In my PICU, probably there are two main changes that are going on at this very time, at this very moment. The first one is that we are moving our PICU in another building, another unit, which is bigger and which is new and which is very interesting because it's full of colors, the background of all the walls. It's an aquarium with all the fishes, and so it will be a great improvement for my PICU. And the second thing that we are doing that probably will change and will improve the care of our patients is we are carrying on a new cycle of teachings. We have been doing this for the last probably 6 to 12 months approximately, which is a weekly teaching involving all the fellows and the registrars working in our ICU. And it's really improving the level of care of our patients because it's improving, it's stimulating us and all the fellows and also all the teams involved in the care of patients in studying and being up to date with all the new guidelines.
I'm very excited to be a part of this awareness week. And the first question is what is changing now in the Pizza ICU? So before making this video, I consulted with some of my other colleagues that are working in pediatric critical care settings, so that when I make this video, it would be representative of the picture in my country. This is because of some of the limitations in resources we have, which I will talk about later on in the video. But I consulted, and the general picture is that what is changing in the Pizza ICU practice in Uganda is that with regard that will have an impact on multidisciplinary approach in the PIDS ICU is that training is improving. Training of different specialties or specializations in pediatric critical care, training programs for different pediatric specialists are being opened here in Uganda.
El avance de los conocimientos científicos y las posibilidades de mejora en la tecnología biomédica han facilitado en los últimos años la profundización en el diagnóstico y el tratamiento de las enfermedades que afectan a los niños y los adolescentes en las unidades de cuidado intensivo. La participación de un grupo multidisciplinario en el cuidado del niño permite tener una mirada holística de las necesidades de este ser humano. El cuidado ahora no se centra en atender una patología, sino en atender un ser humano en desarrollo. La atención centrada en el paciente y la familia tendrá un impacto duradero.
Helping siblings to cope with seeing their sibling for the last time as they say goodbye in the critical care unit. Other times it's working slowly with a patient where they're at after an accident or an injury that has debilitated them and they have to relearn how to walk or talk or move. And my goal is always to bring some fun and some lightness, but always to speak the truth in a developmentally appropriate way that allows kids to thrive in environments that could be very challenging to them. Last several years, there has been more consideration of increasing the multidisciplinary team and really maximizing everyone's effects. So obviously, when everyone works together, the patient and family get the very best experience. And I think it's just going to continue to grow and thrive. There's lots of research on the benefits of working together and including developmental needs, family-centered care, and all of those aspects. I think as we learn how to be better teammates, we also learn to show up kind of as our best selves, but also to promote that healing and coping together. So I think the way forward looks bright, and that there's lots of learning ahead for everyone. And I think more and more research continues just to demonstrate the importance of multidisciplinary therapies into overall good quality care.
Changing now in ICU is 3 out of the 5 existing pediatric intensivists, which is quite a big change. And also we have lost many experienced PICU trained nursing staff, which will impact hugely on our multidisciplinary team.
One of the most important changes in our PICU is including different medical specialties during round to discuss the patient situation and to come up with the most applicable and the best medical decisions.
As a pediatric respiratory therapist, the most lasting impact in our multidisciplinary PICU care would be the practice of new normal policies or protocols in delivering aerosol-generating procedures, namely nebulization, CPT, suctioning, intubation, and the use of viral filters in non-invasive ventilation, such as your bag valve mask, your high-flow systems, your CPAP, and your BiPAP, including the use of aerosol boxes to mitigate the spread of infection during delivery of these procedures.
So when I think about what's changing now in our PICU that will have the most lasting impact going forward, I really can't ignore the fact that we are all living in a pandemic that's changed so many aspects of our day-to-day lives, and particularly our lives at work. So for me, as well as all the challenges, the biggest positive change I truly hope won't go away were the amazing collaborations that we all owe to COVID. Over the past year or so, we have learned to work with each other. We've learned to learn from each other and to educate each other in ways that we wouldn't have dreamt of before. And this is regardless of the distance or ability to travel. Just think, I'm recording this piece today on Zoom, and most of us, certainly I hadn't heard of Zoom before 2020. But this ability to connect remotely has really brought us all together. And I almost think of it now as practicing medicine or practicing pediatric intensive care without borders.
As a dietitian, our biggest challenge is to prevent malnutrition during PICU stay by making sure that our patients are receiving their all nutritional needs, even during frequent feeding interruption due to many medical procedures requiring the patient to be in PO.
So when I think about what lies ahead in terms of PICU practice in the 5 years or the few years ahead of us, the first thing I hope is that we don't forget the positives that we have taken away from this pandemic. Whether this relates to new collaborations, new friendships, or even new ways of practicing medicine, I really hope that we hold on to these positives going forward. But as well as this, and I'll switch gears and stop talking about COVID now, one of my greatest hopes is that we continue to see the role of the ICU nurse to evolve. Without nurses, we as ICU physicians really can't function. Many of us have learned as much from nurses as we have from our medical colleagues, from our bosses, from our mentors, from our textbooks. So my hope is that the role of the nurse as a practitioner and a colleague and a key member of the care team will be front and center for us all as we move into the future.
For question 2, what is the biggest challenge you see in your PICU practice in the next 5 years? The biggest challenge will probably be staffing employment, staff retention, and clinical expertise.
More children with complex healthcare needs are requiring intensive care. Healthcare professionals should evolve together with the healthcare needs of our patients. Skilled and experienced PICU nurses play a pivotal role in enhancing patient safety and health outcomes. One of the biggest challenges is in attracting new nurses specializing in PICU to join this meaningful profession and to continue to upskill and retain the current PICU nurses.
En el plano kinesiológico, en áreas críticas pediátricas, nuestro desafío apunta a desarrollar la mayor cantidad de evidencia científica que permita exponer los buenos resultados desarrollados de forma empírica en nuestros centros de trabajo y además fomentar el desarrollo de nuestra especialidad en el futuro a través de residencias de formación o en los centros con mayor experiencia, favoreciendo el progreso de nuestros especialistas para que sigan de esta manera aportando mediante conocimientos específicos y basados en terapia respiratoria y fisioterapia pediátrica, para de esta manera también, ¿cierto?, aportar desde nuestra área en el manejo de nuestros niños en cada una de las unidades de paciente crítico pediátrico en nuestro país.
The biggest challenge that I see in our PICU practice over the next 5 years will be to ensure that the bridge between technology and actual patient care does not widen and to maintain an optimal level of expertise within our critical care setting.
So I think coming out of COVID, and I'm hoping that is soon, but it has had some substantial negative effects, especially on parents with only, currently we're allowed to have one parent at bedside, and then there's sometimes back and forth of having two, but siblings have really been cast aside in honor of trying to protect the health. We've neglected some of the challenges of that emotional well-being pieces, those connections and development have been impacted. And so I think it actually will take us a little while to figure out how to reintegrate in a safe manner to allow every member of the family to fully participate and be welcomed back in. And I think that there might be some fears and apprehensions that go along with that. So I think it'll be curious to kind of see how we move forward. And I think we had a lot of good things in place with family-centered care before, and some of those have had to kind of subside in differing ways, just in honor of promoting, keeping COVID at bay. So I think that will be our challenge.
The biggest challenge I see in PICU practice in the next 5 years is the full implementation of the clinical risk management as to the capacity to integrate the new normal policies in the respiratory therapist's workflow, focusing not only the patient safety, but the healthcare safety will include space expansion, adequate number of RT staff, sufficient supply of respiratory therapy equipment, and effective communication will sustain a safer, eco-friendly workplace.
The biggest challenge I see in the next 5 years in pediatric intensive care is to apply the precision medicine and to use the artificial intelligence to set up new therapeutic algorithm based on the enormous amount of data we are collecting every day in our clinical practice. This will surely open a new exciting area, a new exciting way to take care of our children.
Well, what is the biggest challenge in my PICU in the next 5 years? The first challenge probably is related to the last improvement and change that we are carrying on, which is the challenge of change the practice of our PICU based on evidences and not just on what we are used to do and what we are doing so far. And this is always difficult to have everyone on board on these changes. And another challenge, which is very difficult in Italy, and it's a big challenge, is to change the nurse to patient ratio and to hire more nurses for the job. The problem is not that the nurses are not interested in working in our unit, in our ICU, but the real problem is the money missing, and we don't have money to hire new nurses. And actually we have a nurse to patient ratio approximately of 2 or 3, so we have 1 to 2 or 1 to 3, so we have 1 nurse for 2 or 3 patients, which is not really ideal in a pediatric intensive care unit.
In Aotearoa, New Zealand, the biggest challenge in PICU practice for the next 5 years is to address inequity and institutional racism. We must address this through prioritisation of our Māori children, Māori governance, and addressing the issues of poverty and bias. We must manage the demands of an increasing number of technology-dependent children, in addition to the general increase in patient numbers and acuity with limited resources. Our challenge is to sustain our staff enthusiasm and psychological well-being and focus on connection and our staff feeling valued, despite the chronic fatigue and dysphoria of our COVID world.
El mayor desafío que tenemos en los próximos años será el darle un impulso a la enfermería basada en la evidencia. La producción científica basada en la investigación con un enfoque reflexivo e interpretativo tendrá que estar más disponible para la toma de decisiones sobre el cuidado de cada paciente. Por medio de la investigación se podrá hacer visible el cuidado invisible que por años llevamos realizando, pero ahora por la globalización de la salud reclama ser evidenciado. Nuestros pacientes en las UCI requieren una atención individualizada, por lo que la enfermería basada en la evidencia constituye una pieza clave, ya que garantiza que la práctica enfermera sea efectiva y eficiente.
Obviously, having sufficiently trained PICU staff is probably the biggest challenge ICU is facing in the next 5 years.
COVID being ever present in our lives right now, I have no doubt in my mind that it already has changed the landscape, and how that's going to look 5 years from now is unknown. But I think what is really important is if the restrictions are still in place for parental presence, we need to be really creative in finding ways for parents to be present and in finding ways to continue to be very family-centered.
In the next 5 years, the biggest challenge I see in my PICU practice is the increasing population and poverty. This will make the delivery of quality and affordable critical care to the needy a difficult task, especially in the absence of universal health coverage. We need to strengthen the entire healthcare setup from primary care upwards to tackle this challenge. For this, the role of healthcare professionals and the society in general will be very important in planning and increasing investment in healthcare.
Developments in technology and medicine have resulted in significant increases in survival rates in many of our PICU patient populations, whether it be the post-trauma or post-acute illness groups, or the children with chronic and complex conditions such as cerebral palsy or spinal muscular atrophy. However, as we know, alongside this increased survival comes increased morbidity. Recent research has highlighted the long-term implications of PICU admissions on the physical, cognitive, emotional and social functioning of a child, as well as the lasting effects on parents, siblings and the family unit. I believe the biggest challenge in our PICU practice in the next 5 years will be responding to this research with action and using it to change our practice. This work has already begun in some units with the implementation of the PICU Liberation Bundle. For many units, it won't be as simple as providing education or changing protocols. A change in culture and a complete overhaul of how we do things will be required. Caring for these critically ill children has become so medicalised, and we need to peel back the layers of this and get back to basics. Additionally, it may require culture change in teams and wards across the hospital in order to optimise the care of a critically ill and medically complex child.
The challenge that I see is that I've talked about improvements in training, making specialists more available to manage children in the pediatric critical care setting, but it is not increasing significantly to manage the demand. The demand is still very big. For example, if you have one specialist per for example, if I can give an example of neonatologists, there is currently 2 neonatologists in the whole country for a population of 40 million people. There's 2 pediatric neonatologists, 2 neonatologists. So even if there's a training program and they're training some few other people, there is still a big shortage in human resource to manage pediatrics or to manage children in a critical care setting. Having said that, besides those shortages, there's still a big challenge that the realization of the importance of specialization is being contested with massive shortages in resources. So you find that even when if I talk about the rehabilitation setting, even when you get training to say a certain specialization just to manage children, you find that as a physiotherapist in practice, there is few of us. So you find that specialization becomes counterproductive. Like it is not possible to practice in just what you've specialized because the demand is still very high. So the few human resources that we have must be stretched to see that everyone gets something.
One of the main challenges at the unit, how to enhance the environment to maintain staff resiliency and reduce work stress related issues. We're working as a multidisciplinary approach to have a better well-being for the staff and for the environment, which has helped us as one team to overcome new challenges during the pandemic crisis.
Generally, I think that, or from my experience, I've seen that involvement of family has the biggest effect on reducing or fastening the process of discharge for children from the intensive care unit. As a rehab professional, I've seen that, first of all, for us, it is pertinent that the family is involved for purposes of continuity. So if you say that you're going to do certain exercises or certain positioning techniques for this child in the intensive care unit, and then the plan is to discharge them to the ward and then eventually home. Because of our resource constraints already, you may find that the care reduces as they go further down, or they may not. If they are lucky to get it in the intensive care unit, you don't know if they'll be able to get the same care on the ward, and if they will get this at home. So teaching the parents or the family how to manage the child, the simple therapeutic techniques, then ensures that the child gets the intervention they need, whether or not the therapist is around. So I can't even stress enough how, for us, family is part of the management of children in critical care settings.
Well, I think the family has the role to bring the voice, the videos, the cuddles, the music of the family at the bedside. And I think this is the best neuroprotective strategy we can prescribe to our sick children. It's the best way to protect their brain in the long term.
So believe that the role of family starts much before the child comes to PICU. Seeking early medical attention in the course of illness is of utmost importance in improving the outcome of the child. With improving literacy rates in low and middle income countries, caregivers are now more informed about the condition of their child. So it is important to establish a good communication with them and involve them in the decision making from the start. In resource limited countries like ours, the nurse to patient ratios are not ideal, and parents may play an important part in the bedside care of the child. Finally, with improving survivals, some children may require continuation of care at home where the family needs to transition into primary caregivers with appropriate training. Thus, the family plays a major role in the care of child before, during, and even after the PICU.
Cuando ingresa un niño en estado crítico, indudablemente también ingresa una familia completa a la unidad, con problemas no físicos, pero sí a nivel psicológico y social, por lo que la familia se constituye en un sujeto de cuidados en las UCIs pediátricas. Se puede observar que las necesidades de la familia del niño en estado crítico son de mantener el contacto físico, la interacción, la comunicación asertiva, y en la medida que estas necesidades sean satisfechas, la familia se equilibra y puede ser de gran ayuda para recuperar a este ser humano. El amor es el que alivia, calma, ayuda y rehabilita, por lo que el papel de la familia es fundamental dentro de las unidades de cuidado intensivo pediátrico. Gracias.
Can't any longer talk about a care team without considering the family. And for me, and hopefully for all of you, the family is a core member of the multidisciplinary team. There's plenty of evidence in all ICU settings that family presence during rounds, the participation of the family in the care of their child, is a great satisfier not only for them, but for all of us as the clinical team, and obviously for their child. And really that participation and that membership of the team and functioning as a colleague is something we really need to foster and to promote going forward.
Whilst we may be the experts in medicine or therapy, the family is the expert in their child or our patient, and it is only by working together as a team that we can improve outcomes. When a patient is admitted to the intensive care unit, we ask the family about them, their medical and social history, their likes and dislikes, and so forth. This gives us the opportunity to paint a picture in our mind of what we think might be going on and what outcomes we're aiming for. On the other hand, the family are scared and vulnerable. They don't know what to expect or what may happen day to day in the PICU. Most families won't have been in this situation before or have another admission to compare it to. Due to this lack of knowledge and expectations, it's hard for the family to advocate to improve PICU outcomes for their child. In Australia, there is currently work being done to create a PICU website with the goal of providing patients and families with age-appropriate information of what to expect during their PICU stay end in their life after PICU.
And family involvement is essential to improving PICU outcomes of children. It's important to involve family members in the care as well as decision-making whilst children are in ICU, which will hopefully improve their long-term outcome.
Family support is very important to improve the PICU outcomes, especially the mother. She can come to visit the baby and hold him if it's possible, and by providing breastfeeding.
Sort of like some quiet and subtle ways that I ask them to tell stories about who they are and how their family functions. And sort of one highlight moment came out of a big challenge where we couldn't have the siblings in last summer due to some of the COVID precautions. So we managed to bring the ICU patient outside and did a little ceremony and celebration of their life before they left this world. And my preparation for the siblings was involved when I walked them around the hospital and I talked about, tell me what you love about your brother. Tell me what kinds of things, what do you believe about life and about death, and what are you expecting to happen? And they gave me these beautiful golden nuggets and memories of who he was. And so I walked away from that scenario just recognizing the importance of individualizing their care and allowing the siblings to participate even if it's a non-conventional way. And so just becoming creative and like keeping them safe, but still very involved. I experience and hear a lot of the parents' fears and helping them to be able to, even in the face of fear, to be able to still parent and have a role, and the importance of them being present and supported the whole time.
Partnering with the family serves as a bridge between patient and the team. One of the best witness practices in our PICU is the open, honest, clear communication between the family and healthcare team. Thus, family empowerment as to decision-making and their confidence in the delivery of childcare plays a vital role in improving PICU outcomes.
The families are the front line for their children at their homes. They do 24/7 what's being done in the hospital. I myself have what I like to say is a mini ICU in my home. We do it all here. In the hospital, unfortunately, the healthcare providers there don't get to see Nikki when she's at her happiest. They don't get to see children outside of their illness. And I bring that perspective to the table. I also bring the perspective of the 24/7 care and the meetings with all of the other team members to the table. It's all up here. And that knowledge and wisdom and insight, it can be extremely valuable to the team members.
Una de las pruebas más complejas que una unidad de cuidados críticos pediátricos tiene que abordar es el sufrimiento del paciente y de la familia que lo acompaña. La integración de la familia en el cuidado del paciente y la comunicación eficaz con el equipo interdisciplinario que compone la unidad de atención aumenta la satisfacción del grupo familiar, incidiendo directamente en la percepción de la calidad de atención, ayudando a la recuperación del paciente, en el control del dolor, ansiedad y aumentando la adherencia del tratamiento. La verdad es que de esta forma, al integrar las familias, se fomenta la humanización de los cuidados en pediatría, viendo al niño de una manera holística y no solo de una enfermedad, a lo que hay que intervenir. Y de esta forma el paciente y sus familias afrontan de mejor forma el proceso.
It's very interesting because I just had an experience abroad as a fellow, and I could compare the family role in both countries. I was in UK, and what I can see and what we need to improve also probably outside this pandemic, this COVID pandemic, is trying involving more the families in the care of the patient 24/7, probably in our unit, which is not easy so far. The families can stay only during the day in the afternoon, also for the COVID-19 situation. And also we would like to involve, or I would like to involve more the families in patient care, like, for example, to teach them how to do the physio and to involve them in the physio, also in order to to stimulate a early mobilization. So I think that we can include the family in the healing process of the patients.
That continued reminder of the developmentally appropriate ways and that compassionate care makes a difference in healing and outcomes. And for that family, they'll always remember that one of the first people she talked to was me when she could finally use her voice. And so I still get follow up with her from time to time. And she speaks positively of her PCCU journey and the way that everyone took really good care of her and cared about her, the wholeness of who she was, not just her medical needs.
Our whānau, families, have a pivotal role to play in improving PICU outcomes. We need a greater patient and whānau voice, and in Aotearoa, New Zealand, we need to hear in particular from our Māori and Pacifica whānau about how to address institutional barriers, to work with them as equal partners and effectively meet their needs and those of their children. We need to engage our whānau more fully as active participants in their children's care and to truly value their views. He aha te mea nui o te ao. He tangata, he tangata, he tangata. What is the most important thing in the world? It is the people. It is the people. It is the people. Tēnā koutou katoa.